After a pretty long hiatus, thanks to the sudden opening of medical colleges all across my country and the sudden onset of examinations as well, for the last 2 months, I suppose, I could not upload anything. So sorry for that. And before the onset of my next examinations, I had some spare time. So I thought, yeah, let's make some uh, good videos again, which are pretty important for the first professional examination and from the knowledge perspective as well. So, in that context, the topic that we study or discuss rather today in this video is the anterior abdominal wall, which is the topic of abdomen, as we all know, and it's the first topic of abdomen actually. So, as far as the anterior abdominal wall is concerned, we all know that any anatomical domain, whenever we start studying any anatomical domain, we always start with the superficial structures first. Anterior abdominal wall or anterolateral abdominal wall is no exception to that rule. We do start with skin, then superficial fascia, then we go into the deeper structures. But in this discussion, what we are going to do is we are going to start straight with the muscles. All right. And the reason for that is that the muscles of the anterior abdominal wall, they are the most important aspect as far as the knowledge of anterior abdominal wall is concerned. So as you can all see, we have already exposed. So think of this as a dissection. All right. Think of this model as a dissected model of an actual human cadaver. All right. So we have already dissected out the skin. We have dissected out the superficial fascia. Now we are seeing this whitish structure along with these muscle fibers along with it. And along with that, we are also seeing a median whitish fibrous raphe. This is the first impression that we have, right? So let's start then. Okay. The anterior abdominal wall, as far as its muscles are concerned, the muscles in the anterior abdominal wall are actually arranged in several layers. All right. So the first superficial layer that we are seeing here is this muscle, which is the external oblique. Okay. So this is the external oblique muscle. If we remove it, we'll subsequently come on to the next layer, which is the internal oblique muscle. Okay. If we remove even that, we will get this muscle in the anterolateral abdominal wall, which is the transversus abdominis muscle. Along with these three anterolaterally oriented, superficial to deeply arranged layers of muscles that we saw, we also see this median muscle, which is the straightly oriented and hence called rectus abdominis muscle. As I said, straight, so it's rectus. As we all know, rectus means straight, right? We also find rectus femoris and rectus capitis posterior in the suboccipital triangle and all of that. So rectus means straight, vasa recti, straight vessels. So rectus abdominis means a straight abdominal muscle. All right. These are the four muscles that actually more or less comprise the anterior or the anterolateral abdominal wall. And these are the four muscles that we are going to talk about in this discussion of ours. Another muscle is sometimes present. It is not always present. It is sometimes present. It's not given over here. It's not shown in this model. But in any standard textbook, you can get the name of that muscle. That muscle is called pyramidalis. All right. Pyramidalis. We all know the spelling of pyramid. Along with that, alis. A-L-I-S. Pyramidalis is a muscle which is not present always. So it's not present in everyone, but if present, it is actually present in the, along with the rectus abdominis muscle in the inferior section, somewhere over here, right? It's not that important of a muscle, so we are going to ignore it, right? Now, having discussed about the overall distribution of these four muscles, let's now talk about each individual muscle. We'll pick up one individual muscle, we'll talk about its attachments, and then we'll talk about how it is actually oriented in the anterior abdominal wall. Okay, let's start with the external, or rather, yeah, the external oblique. Let's start superficially, then we'll go deeper. Okay, let's start with the external oblique muscle. So, this over here, as you can all see, is the external oblique muscle. Now, so what is the origin of external oblique muscle? As you can already see, it has something to do with these ribs over here. Can you see? It is taking origin by these slips, these fleshy slips from these ribs. So to be a little bit more formal, if we are to be more precise, we will say that the external oblique muscle takes origin by 8 fleshy slips from the outer aspect of the middle of the shaft of the lower 8 ribs. Am I clearly understood here? If not, I'll repeat it again. First of all, the thing that you need to understand this first, is that external oblique muscle takes origin via fleshy slips. As you can see, these fleshy slips, they are actually taking origin from these ribs, right? So that's one confusion dealt with. Second thing that you need to, I would say, memorize in this aspect, you have to memorize, or rather remember this, that what are the ribs from which the origin takes place? The lower 8 ribs. 1, 2, 3, 4, 5, 6, and here is 7 and 8, as you can see. Okay, so the lower 8 ribs, from the lower 8 ribs, external oblique is taking origin. From where exactly of the rib? As we know, or rather we will study later in the rib anatomy, that a rib has a head which is posteriorly oriented. If you can see my mouse pointer, this over here is the head. Then there is a constricted neck. Then there is the entire curved shaft or body of the rib. So we are saying that the external oblique is taking origin from the shaft, not from the head or neck, from the outer surface of the shaft, because the shaft has an inner surface as well. The outer aspect, or rather the outer surface of the shaft of the lower 8 ribs, where, to be a little bit more precise, middle of the outer aspect of the shaft. So there are so many pointers to this, and why I'm actually being so much precise about this, not only has to do with gaining the knowledge about this origin, but also with a little bit of viva, right? So in many, I've seen so many viva examiners who are very precise with at least gross attachments of muscles like these. I mean, if you're asked the origin and insertion of very minute muscles, the examiner might be a little lenient towards the attachments. But in such gross structures, the insertion origins, you have to be pinpoint precise. Now, having talked about the origin of the external oblique, let's talk about the insertion. The insertion is much more, I would say, extensive than the origin is. The origin was completely from the ribs, but the insertion is not only to a single point or single line. It's a lot more extensive. How? First of all, the thing that you need to at least realize here is that external oblique, internal oblique, transversus abdominis, all of these muscles, they have a fleshy muscular part, and then they also have a very extensive midline aponeurotic part. All these muscles. If you don't know what aponeurosis is, by the way, aponeurosis is nothing but the flattened tendon of a muscle. So a muscle attaches by its tendon. If the tendon is not cylindrical, rounded, but rather flattened, it forms a structure called aponeurosis. Okay, all the abdominal muscles, or rather all the muscles in the anterolateral region of the abdomen, actually have a extensive aponeurotic origin, insertion, whatever. We'll talk about that later. So external oblique also has this huge aponeurosis, as you can see, aponeurotic sheath. So where exactly does it insert? Okay, let's start from the superior aspects, then we will descend downwards. First of all, the external oblique inserts along the xiphoid process. If you don't know what a xiphoid process is, chances are you know it. Xiphoid process is this sharp process at the inferior most point of the sternum or manubrium sterni. All right, it's a process which is extending from the manubrium sterni, and it serves as the point of insertion of all these anterolateral abdominal wall muscles. Okay, so the first thing is it gets inserted along the xiphoid process. Coming inferiorly, now here is a very conceptual thing. The next point of insertion, or rather the next line of insertion, is along the linea alba. This whitish fibrous raphe that is median in position, as you can all see here, is known as the linea, means linear, straight. Alba means white, so a white line. What this linea alba is, we'll talk about that in a bit. All right. So xiphoid process, then along the linea alba, it keeps moving, then it reaches the pelvic region. In the pelvic region, it will actually insert along the, over here, the pubic tubercle and the pubic symphysis as well. As you can see, the pubic symphysis is somewhat median in position between the two pubic bones. Into the pubic symphysis, the pubic crest, if you cannot see, okay, yeah, here it is, the pubic crest along the pubic bone, and then along the pectinate line, which is not, yeah, here, as you can see here. Can you see this line? This is the pectinate line of pubis. When we'll study about hip bone anatomy, we will talk about these in much more detail. But for now, just try to understand that first of all, it's the xiphoid process. Secondly, it's all across the linea alba, then moves into the pubic region, inserts along the pubic symphysis, the pubic crest, and along the pectinate line of pubis, which is along here. Okay, right. That's one part of the insertion dealt with. There is another part of the insertion. Where exactly? That part of the insertion is along the iliac crest, as you can see over here. So one part of the insertion is at midline, the other part of the insertion is along the iliac crest. So the external oblique also inserts, mind my words, along the outer lip of the iliac crest, or to be more precise, the anterior two-thirds of the outer lip of the iliac crest. The iliac crest has, if you can see, this is the iliac crest. This is the iliac bone of the hip bone. It has this huge crest, the iliac crest, which has three lips. The outer lip, then there is the intermediate lip, then there is the inner lip. Along the anterior two-thirds of the outer lip, we get the insertion of the external oblique. Then we also have the midline insertion of the external oblique, which I just mentioned. We also have the origin of the external oblique along these lower 8 ribs. So one thing that we can appreciate is that there is a free margin of the external oblique. and this is the posterior margin of the external oblique, which is free. Also, as you can see, this upper margin, this is free as well. This is free as well. So it has this upper margin which is free. It also has this posterior margin which is free. So that's the origin and the insertion. You have to remember these individually and not merely as attachments. That's why I said so much earlier of external oblique. Now, very quickly, you can visualize how the fibers of the external oblique are running, or rather the direction of the fibers of external oblique. Direction of the fibers of external oblique, as you can see, is downwards, forwards, and medial. If you are unable to visualize it in this model, you should be able to visualize it, but if you're unable, try to visualize how your hand moves when you put them into your pockets. Try to think of that. When you put your hands in your pockets, do not your hands move in the same direction as the external oblique moves? Downwards, forwards, and medial. Think of this, right? So that exactly is how you remember the direction of the fibers of external oblique. If you remember the direction of these fibers, you'll remember the direction of internal oblique and transversus abdominis as well. They are not that difficult, right? Right. Now, having talked about these, uh, let's move on to some other very interesting aspects of the external oblique. You may notice something. I talked about this aspect. I talked about this pubic aspect. And I also talked about this insertion. But we are left with one major part of the external oblique that we did not talk, and that is this aspect. Why did I not say that this inferior border of the external oblique is free as well? You just now heard me saying that the superior border is free, the posterior border is free, but I did not say that the inferior border is free. But it does look like it is free. Why is it not free? Why are we saying that it is not free? Because, interestingly enough, what happens is external oblique, when it is running downwards, as I said, downwards, forwards, and medially, in the inferior most aspect, it doubles down on itself. That is, it folds upon itself. So these are the fibers. They fold internally, right? And form an arched surface. They form this arched line. This folded part of the external oblique's inferior border extending between the anterior superior iliac spine, as you can all see, this is the anterior superior iliac spine, to this over here, which is the pubic tubercle. This part of the external oblique, which is folded upon itself to form this structure called the inguinal ligament. So we are calling this structure as the inguinal ligament, which is nothing but the arched part of the inferior border of the external oblique. So think about it. Is a ligament supposed to be like this? It's not actually supposed to be a part of a muscle, is it? All the ligaments that we have studied, normal ligaments, they don't actually show any peculiarity like this. They're not parts of muscles or as such. So that's why what we say is this inguinal ligament is a false ligament. It's not a true ligament. We'll come across many such false ligaments later. But this is the first stop in the false ligament station. That is the inguinal ligament. Right? Right. And as you can see over here, this is a ring-like structure, an opening in the external oblique present at the inferior most or rather anterior most part of the inguinal ligament. This is what we call to be the superficial inguinal ring. We'll talk about this structure along with the entirety of the complex anatomy related to inguinal canal when we talk about inguinal canal. If you don't know, the superficial inguinal ring is related to inguinal canal. So that is all about external oblique. There is another information about external oblique, and that is the fact that it is supplied by the lower 6 thoracic nerves. that is T7 to T12, right? T7, T8, T9, T10, T11, and T12. T12 is subcostal nerve plus the lower 5 intercostal nerves. Okay, so that's the nerve supply of external oblique muscle. Now let's go back, or rather let's get one layer deeper and talk about this muscle, which is the internal oblique muscle. This won't take up as much time as external oblique. So internal oblique muscle, what the direction of these fibers, let's first get on with the direction. The direction of these fibers, they are, as you can see over here, this was the direction of the external oblique, right? Downwards, forwards, and medially. The direction of internal oblique fibers, they are 90 degrees or perpendicular to the direction of external oblique. So they will be upwards and medially. Okay, they will be upwards, forwards, and medially, not downwards, forwards. They will be somewhat upwards and medially, as you can see over here, since they're 90 degrees to the external oblique fibers. So what about the origin and insertion of the internal oblique? Now, here is the first thing, or rather the next thing that you need to remember. External oblique's origin was superior, right? It originated from these lower 8 ribs, which were superior, and its insertion was midline, inferior, and posterior. Inferior internal oblique, on the other hand, along with transversus abdominis as well, their origins are inferior. Their origins are inferior. Okay, their origins are inferior, and their insertions are superior and midline. And that is what gives the direction of these fibers, right? Since they're coming from over here inferiorly to superiorly, that's why the direction of the fibers is 90 degrees to the external oblique. Correct? Right. So what is the origin then? Okay, again, we'll follow a line here. The origin inferiorly of the internal oblique is along the intermediate lip of the iliac crest, but not the entire intermediate lip, anterior 2/3 of the intermediate lip of iliac crest. So the anterior 2/3, this is a constant thing. External oblique, anterior 2/3 of outer lip of iliac crest. Internal oblique, anterior 2/3 of intermediate lip of iliac crest. Later in transversus abdominis also, anterior 2/3 of the inner lip of iliac crest. Okay, so that's one thing which is good for us for remembering. We don't need to remember other numbers. So that's the first point. But see, the origin is not merely up to here, it is extending. So what structure did I just mention extended from the anterior superior iliac spine to the pubic tubercle? What was that specialized structure? Arched fibers, the upturned fibers of the folded fibers of the external oblique? Yes, the inguinal ligament. So the lateral 2/3 of the inguinal ligament also gives origin to the internal oblique. The lateral 2/3. Obviously, it cannot be the medial 2/3 because we are talking about a continuous line extending from the iliac crest. So obviously, it has got to be the lateral 2/3, right? So lateral 2/3 of the inguinal ligament. There is another origin of the internal oblique, which is posteriorly located over here, as you can see. So we cannot say that the internal oblique has a free outer or free posterior margin as such. This is not that well visualized in this model, but in posterior aspect of our body, we have a fascia which covers the internal aspect of the back muscles. It is known as the thoracolumbar fascia. We'll talk about thoracolumbar fascia later in a later discussion in much details. Okay, so see, the internal oblique's origin is along a continuous, you might say, line. Thoracolumbar fascia posteriorly, then the entire intermediate, not the entire intermediate lip. This was a test. I almost fell for my own trap. Not the entire intermediate lip. See, the posterior part is missing. From the anterior 2/3 of the intermediate lip of iliac crest, then from the lateral 2/3 of the inguinal ligament. What about the insertion? Well, as you can see, the uppermost fibers the uppermost fibers of the internal oblique, what they will do is, now we'll see a common trend. What we will see is that both internal oblique and transversus abdominis, they have insertions along the costal, you might say, margin or costal cartilages and the ribs. That is, what formed the costal margin, if you remember, the costal margin was formed roughly by the lower 3 or 4 ribs, right? The lower 3 or 4 ribs from the 7th rib onwards, they form the costal margin along this line over here. Along that costal margin, both internal oblique and transversus abdominis, they get inserted. So the uppermost fibers of internal oblique, we might say that they are inserted directly into the lower 3 or 4 ribs. The lower 3 or 4 ribs and their costal cartilages. Okay. Now, that's one point of the insertion. But as I've said, since these muscles are very extensive, that's not all. The next part is, again, just like the external oblique, along the aponeurosis of the internal oblique. That is, the greater part of this internal oblique muscle, most of the part rather, that is actually inserted onto the, or rather, that actually ends in this broad aponeurotic sheath. Where does this broad aponeurotic sheath get inserted? Almost the same line along which the external oblique aponeurosis had gotten inserted. That is the same, the xiphoid process, linea alba, and all of that, right? But along with that, this aponeurosis is also inserted along the 7th, 8th, and 9th costal cartilages. And it's pretty well visualized here as well. You can see, I said that along a continuous line, the internal oblique is getting inserted. So the broader muscular part, that actually gets inserted along the lower 3 or 4 ribs and the costal cartilages. But the broad aponeurotic sheath, that is getting inserted from the 7th, 8th, 9th costal cartilages. Sorry for the lag there. The 7th, 8th, 9th costal cartilages, along them, they are actually getting inserted. So from the 7th to 12th ribs, we get the insertion of the internal oblique. Okay. The remaining midline insertion is the same, broad aponeurotic sheath, linea alba, xiphoid process, right? Then the pubic crest again, pectineal line again, same. So that's about the origin and insertion of the internal oblique. Now, having talked about the general aspects of the internal oblique, let's talk about a bit of the special features of the internal oblique. Although these features will be described a little later when we'll talk about the rectus sheath formation, but for now, the thing that we need to realize is this internal oblique, although it appears to be over here as a single muscle lamina, but what happens in reality is that in the upper part, or rather the upper 3/4, it remains as a bifurcated lamina. What that means is that the internal oblique, it will actually split into 2 lamina. I'll talk about this in much details a bit later. We'll see the diagrams and all of that later. But for now, since we are talking about internal oblique, so I'm mentioning this. In the upper 3/4 of its insertion, as its aponeurotic form, it actually splits into 2 lamina, the anterior lamina and the posterior lamina. The anterior lamina is anterior to the, you might say, the rectus abdominis muscle, forms the anterior layer of the rectus sheath. We'll talk about it later. And the posterior one will form the posterior lamina of the rectus sheath. However, at a level midway between, as you can see, this is the umbilicus. We all know what the umbilicus is. So at a level midway between the umbilicus and the pubic symphysis, midway between, so somewhere over here at this level, somewhat, the posterior lamina of the internal oblique abruptly ends. Abruptly. All right, gone. Only the anterior lamina is continuous, no problem. But the posterior lamina, In the upper 3/4, it's there. But in the lower 1/4, from a level midway between the umbilicus and pubic symphysis up to the inferior part, it's no more there. It abruptly ends. It ends in a curved way and forms what we say to be the linea semicircularis. So the line which is formed, we'll talk about it again. I'm saying this for the third or fourth time. We'll talk about this in details later. Linea semicircularis is formed due to the abrupt ending of the posterior lamina of the internal oblique at the level midway between umbilicus and the pubic symphysis. In a curved margin, it will end, forming a line called the linea semicircularis, also known as the fold of Douglas, also called the arcuate line. So it has three names: fold of Douglas, arcuate line, linea semicircularis. So we talked about linea alba. Oh, we haven't talked about linea alba yet. We'll talk about it in a bit. But we know about linea alba. We now talked about linea semicircularis. And we have another linea. It is known as linea semilunaris. Let's talk about it right now. Okay. So linea semilunaris, what happens is, if I remove this, although it's not very visible, you might visualize it. Linea semilunaris, it's not that important of a line, but what it is that it is found in the lateral margin of the rectus abdominis muscle or the rectus sheath. We'll talk about it later. In the lateral margin of the rectus sheath, the rectus abdominis muscle, the border along which the muscular part of the anterolateral abdominal muscles become aponeurotic. This lateral margin is called the linea semilunaris, not semicircularis, linea semilunaris. All right. So it actually extends from the tip of the, or rather the costal cartilage, or from the costal margin up to the, it's not given here very well, up to the pubic tubercle, or rather the pubic crest, actually, if I'm to remember correctly. So it's a laterally oriented line, which is nothing but the significance of that linea semilunaris is that it is representing the line along which the muscular part of all the three abdominal muscles, they are becoming aponeurotic. So this line that you can see, this is the linea semilunaris. Okay. Okay. So that's that about the internal oblique muscle. Internal oblique muscle, it also forms some other specialized structures. Again, we'll talk about it later when we talk about rectus sheath. Now, as you can all see, this is the transversus abdominis muscle. The transversus abdominis. Oh, by the way, the internal oblique muscle's nerve supply. If you remember, the external oblique was supplied by the lower six intercostal nerves, right? Internal oblique is supplied by lower six intercostal nerves plus the first lumbar nerve. Same goes for the transversus abdominis muscle. Transversus abdominis muscle is also supplied by the lower six intercostal nerves, that is T7 to T12, plus the first lumbar nerve, that is L1. Okay. So transversus abdominis, as you can all see, the direction of fibers of transversus abdominis is horizontal. So it is not like external oblique, downwards, forwards, medial, or like internal oblique, upwards and medial, anything like that. No, it's horizontal, more or less. Okay. So yeah, let's talk about the transversus abdominis in a little bit more detail, shall we? Okay. Transversus abdominis. What about its origin? Transversus abdominis muscle. Again, like I said, its origin is similar to internal obliques. Its insertion as well. So, transversus abdominis, as you can see, it is taking origin from the anterior 2/3 of the inner lip of iliac crest. I have already said that. Very easy to remember. Then, again, a lateral part of the inguinal ligament, but lateral 1/3 of the inguinal ligament. The internal oblique was lateral 2/3. This one is lateral 1/3. I don't know if that's a very important thing to remember. I don't know. But for all intents and purposes, lateral part of the inguinal ligament. Okay. Again, the thoracolumbar fascia. No problem with that. And now there is one more origin of the transversus abdominis. The inner surfaces of the lower 6 costal cartilages. So if I remove this from here, now we can see the entire, you might say, extent of the transversus abdominis muscle. So you can see that it is extending up to the cost. You can see these are the ribs, and these vacant spaces, they are actually what? They are actually occupied by the costal cartilages. Very simple. Transversus abdominis actually takes origin from the inner aspects of the lower 6 costal cartilages. Lower 6 costal cartilages, it takes origin from the inner aspect of that. This, along with the internal oblique, the transversus abdominis, actually the lower fibers, they form a conjoint tendon. We'll talk about it later. Okay, but just to get it straight, most of the insertion is along the midline in this broad aponeurotic sheath, in the same way that all those 3 muscles, other 2 muscles were there. Origin, as far as that is concerned, the costal part origin is there for transversus abdominis, but the costal part origin is not there for internal oblique. Costal part insertion is there for internal oblique, right? So that's an important difference that I just mentioned, and we already talked about the insertion. Okay. Okay. How about the nerve supply? The nerve supply is, as I've already mentioned, same, absolutely same as internal oblique muscle. Now let's talk about the very important muscle, that is rectus abdominis muscle. So as you can all see, this is the right-sided external oblique. By the way, all the muscles that I described, they were on the right side, but that's no excuse to understand, or rather that's no excuse to think that they are unilateral. They are all bilateral. That is, all these muscles are paired structures present on both sides. So what happens is, this rectus abdominis muscle, this is, as you can see, this is a straight muscle, that's why it's rectus, right? Its origin is inferiorly located. Now this is a very important aspect. Okay, and its insertion is superior. All right. Another very interesting aspect of rectus abdominis muscle, although it's not very visible here, is the fact that rectus abdominis muscle has 2 heads. A lateral head, which is laterally oriented, and a medial head, which is medially oriented. They actually fuse to form the rectus abdominis muscle. So the lateral head of the rectus abdominis muscle, that will actually, as you can already kind of see here, it is taking origin from the lateral part of the pubic crest. So this is the pubic bone. This over here is a pubic crest. So lateral part of the pubic crest, over here, somewhere from over here, this model shows the structure very medially. Actually, it's a bit like this, kind of. So lateral part of the pubic crest is actually giving origin to the lateral head of the, you might say, rectus abdominis. Whereas medial head actually takes origin from the medial part of the pubic crest. Medial part of the pubic crest, that is this part. Yeah, this part. Okay, so lateral part of the pubic crest, lateral head, medial part of the pubic crest, medial head, fuse to form the actual rectus abdominis muscle, right? And they run vertically upwards. Insertion of rectus abdominis is, but it has some insertion along the xiphoid process, and it has also some insertion along the 7th, 6th, and 5th costal cartilages, which is absolutely absent here. So this is the fifth, this is the sixth, and this is the seventh ribs. So the costal cartilages will be somewhat like this, right? And as you can very well see that rectus abdominis muscle, it is lying above these costal cartilages and margin. So it will insert onto the seventh, sixth, and fifth costal cartilages. Along with that, it will also insert, as you can see, a little bit into the xiphoid process, but mostly into the anterior thoracic wall. Okay, so that's the insertion. What is the nerve supply of rectus abdominis, by the way? The nerve supply of rectus abdominis is the same as external oblique. That is the lower six thoracic nerves. All right. So T7, T8, T9, T10, T11, and T12. Okay, that is the lower six, or sometimes seven as well. Lower six or seven thoracic nerves. Okay. So external oblique and rectus abdominis, they have the same nerve supply almost, whereas internal oblique and transversus abdominis have the same nerve supply. Now, a very interesting aspect of this is probably the most interesting aspect of the rectus abdominis muscle. That is the presence of these transverse, you might say, tendinous intersection along the rectus abdominis muscle. See what these are, as I've already mentioned, these are transverse because they're transversely oriented, tendinous intersection. So we know that the rectus abdominis muscle, the fibers are running how? Vertically upwards. So they are vertically oriented fibers. But at some points, as you can see, there are these transversely oriented fibrous bands which are called the tendinous intersection, since they're intersecting these tendons, you might say, or muscle fibers of the rectus abdominis muscle. Where these tendinous intersections are present, actually, there are three tendinous intersections. Normally, mostly, again, exceptions can be there, and we will see what the exception is. But normally, there is one tendinous intersection right at the level of the xiphoid process. There is another tendinous intersection right at the level of the umbilicus, as very clearly given here. And there is a tendinous intersection midway between these two other tendinous intersections. Very easy. Xiphoid process level, umbilicus level, midway between them. What is this tendinous intersection all about? As I already said, these are fibrous bands, and these fibrous bands, they're traversing transversely, intersecting the fibers of the vertically oriented fibers of the rectus abdominis muscle. And what they are doing is they are actually dividing the muscle into segments. This is normally what we see in incredibly muscular people, and we see that they have good abs. All right, so this region, this is visible from outside the skin. So what they are doing is they are actually strengthening this rectus abdominis muscle. Think about it. If the rectus abdominis muscle had been a single straight vertically oriented muscle, just like these, without any midline or intervention in the middle, then what would have happened is whenever there would be bowing of the trunk, right? If there had been any kind of bowing in the trunk, that is, you lean forward or anything that would have happened, this rectus abdominis muscle, this would have bulged outwards, right? Can you imagine what would have happened? If you lean forwards and these tendinous intersections, they were not present, what would have happened? The rectus abdominis would have remained as a single vertical band of muscle with this one insertion and origin so far apart from it. This entire thing would have been free. So this would have bulged outwards if you have bowed or bowed down or leaned forwards. So to check the bowing of this, these tendinous intersections, they are very, very important. They make the rectus abdominis muscle very, very viable and powerful as such. Now, these tendinous intersections, we talked about this, right? these tendinous intersections, they are pretty adherent to the anterior wall of the rectus sheath. I said for all the anterolateral abdominal wall muscles that whatever their origin and other points of insertion be, whatever that might be, all the muscles, all the anterolateral abdominal wall muscles, they have this broad aponeurotic part which which has at least an insertion at this midline structure, which we call to be the linea alba. So what is this linea alba exactly? Linea alba, as I said, these muscles, they are present on both sides. So they are paired structures. What happens is the superficial fibers of one side muscle, when it crosses the midline, becomes the deeper fibers for the other sided muscle. So it's not as if this is a separate structure and this is a separate structure. No, these are actually continuous, but in a very different way, right? So they are not a continuous covering as such, but how this occurs is superficial fibers of one side becomes the deeper fibers of the other side, and this is true for all the anterolateral abdominal wall muscles. So think about it. What is happening in the midline? There is a huge zigzag and intersection of tendons. All the superficials are becoming deeps, all the deeps are becoming superficials, all of this is happening in the midline. So this midline raphe, fibrous raphe, which is extending from the xiphoid process up to the pubic symphysis, along which all the tendinous intersections are occurring, all these structures, all the aponeurotic parts of these anterolateral abdominal wall muscles, they are continuing on to the other side, intersecting each other, forming a midline raphe called linea alba. So, having talked of linea alba, having talked of all the anterolateral abdominal wall muscles, we are now in a position to describe the rectus sheath, which I was talking about for quite some time.